Sometimes after you've been through something like a DVT, a deep vein thrombosis,
Yeah.
you think you're over the worst bit, but then maybe your legs stay swollen. Or there's this nagging pain that just won't shift.
Mm.
You start wondering, okay, what's going on now? Well, that could actually be post-thrombotic syndrome, PTS.
Exactly. And that's what we're diving into today. Think of this as your quick guide to getting your head around PTS. We've looked at the key info, the notes you shared.
Yeah.
And the aim is really just to pull out all the crucial bits, make it stick for you, like a high-yield summary.
Perfect. So our mission is clear. Give you that solid overview of PTS.
Mm-hmm.
Really good for revision. We'll cover, what it is, the causes, who gets it, how it actually happens in the body,
Mm-hmm.
how doctors figure it out, what it looks like in the UK, the symptoms, tests, treatments, outlook, and any potential pitfalls or complications. Okay, let's get started. What is PTS?
Right. So PTS, post-thrombotic syndrome, is basically a chronic condition. It's something that can develop after you've had a DVT. It happens because the deep veins in the leg haven't quite healed properly after that clot, so you get these persistent symptoms, potentially complications too.
And the main things to look out for symptom-wise.
Yeah. The key ones are usually pain that doesn't go away, swelling, sometimes skin changes developing over time, and in some cases, even ulcers on the leg. It's like the vein's long-term reaction to the injury.
And it sounds quite common from the notes. Like potentially up to 50% of people post-DVT. That seems huge.
It is, yeah. It's a really significant long-term consequence, which is why understanding it is so important. It really affects a lot of people.
Okay, so where does it actually stem from? This is where it gets really interesting, right? The etiology.
Exactly. The root cause really goes back to that initial DVT. It's the damage and the obstruction caused by that blood clot in the deep veins.
Right.
So the clot itself impairs the blood flow, obviously, but it also triggers inflammation in the vein wall. This whole process can lead to something called venous hypertension.
High pressure in the veins.
Yep, higher pressure than normal inside those veins. And that makes it harder for blood to flow back up towards the heart. Over time, this can become chronic venous insufficiency.
So the veins just aren't doing their job properly anymore.
Pretty much. They struggle to return that blood effectively. Think of it like plumbing that's been damaged and now the drainage is poor.
And is it just the clot itself, or do other things play into whether you get PTS?
Good question. It's not just the clot. The severity of that first DVT definitely matters, like how big it was, where it was located.
Okay.
Also, how well the anticoagulation treatment worked, and crucially, how quickly it was started. Any delays can make things worse. And unfortunately, if someone gets another clot in the same leg,
Oh, that just adds to the problem.
it really does. It compounds the existing damage.
So what does all this mean in terms of who's actually more likely to develop PTS? What are the key risk factors we should know?
Okay, so looking at the risk factors, older age is definitely one. Veins might just be less resilient as we age. Obesity is another significant factor. And as you'd expect, having had a DVT before, especially if it was extensive or if you've had recurrent DVTs.
Right, that makes sense.
And then there's the treatment side, inadequate anticoagulation or starting it late. That's a big one.
Are there other things too, like underlying conditions?
Yeah, definitely. Things like thrombophilia, that's where your blood is naturally more prone to clotting, that increases the risk.
Okay.
Also prolonged immobility, think long flights, bed rest, and sometimes even just the person's specific anatomy if it affects blood flow.
And lifestyle, does that come into it?
It can. Smoking is mentioned.
Yep.
Pregnancy can increase risk temporarily. And other medical conditions like cancer can also be contributing factors. It's often a mix of things.
Wow. Okay, so quite a few potential factors. Now, what's fascinating here is the how. What's actually going on inside the leg after the DVT to cause all these symptoms, the pathophysiology.
Right, let's break down that process. So even after the main clot starts to break down, often bits of it, sort of residual clot, can linger. Plus, you've got ongoing inflammation in the vein walls and actual structural damage to the vein itself. Maybe the valves inside the vein get damaged.
Valves, the things that stop blood flowing backwards.
Exactly. If they're damaged, blood can pool more easily. So all this together, leftover clot, inflammation, valve damage, leads to continued blockage or poor drainage.
And that leads back to that high pressure thing, venous hypertension.
Precisely. That chronic venous hypertension is really central. The sustained high pressure in those bigger veins gets transmitted down to the tiny blood vessels, the capillaries.
Right.
This forces fluid out of the capillaries into the surrounding tissues. That's your swelling, the edema.
Okay, hey.
And it doesn't stop there. The tissues also don't get enough oxygen because the circulation is sluggish. That's tissue hypoxia.
Which probably makes things worse.
It does. It fuels more inflammation, and eventually you can get scarring or fibrosis developing in the vein walls and the tissues around them.
So it's like a vicious cycle.
It really is. High pressure, fluid leaks, lack of oxygen, inflammation, scarring. That whole cascade leads to the classic signs and symptoms of PTS.
Which raises an important question. How do you tell PTS apart from other things that might cause leg swelling or pain? What are the differentials?
That's a really key practical point. Because other conditions can look similar. You mentioned chronic venous insufficiency earlier. That can happen even without a prior DVT.
Right.
Then there's lymphedema. That's a problem with the lymphatic system, totally different cause. Peripheral arterial disease affecting the arteries, not the veins. Or even just straightforward musculoskeletal problems like arthritis or muscle strain.
So you can't just assume it's PTS.
Definitely not. The diagnosis needs proper assessment. That means taking a really good medical history, asking specifically about any past DVTs, doing a thorough physical exam of the leg, looking for those signs we talked about, and then critically, imaging. Usually a venous duplex ultrasound.
The ultrasound scan.
Yeah. It uses sound waves, lets doctors actually see inside the veins. They can check for blockages, see if blood is flowing the wrong way because of damaged valves, look for signs of old clots. It's the main tool.
That makes sense. So connecting this to the bigger picture, what about here in the UK? How common is PTS, epidemiologically speaking?
Well, getting exact numbers is always a bit tricky, as the notes suggest. But the estimates are generally in the range of, say, 20% to 50% of people who've had a DVT go on to develop some degree of PTS.
That's still a pretty wide range, but yeah, even 20% is 1 in 5 people.
Exactly. It's a common complication. And it's important to remember that how often it develops and how severe it gets can vary a lot.
Depending on
Things like where the original clot was, clots higher up in the leg, like the thigh or pelvis, tend to carry a higher risk of PTS. Also how big the clot was, how well it was treated, and just the individual's overall health.
Okay, so let's unpack the experience more. If someone has PTS, what are they typically feeling or seeing? The clinical presentation.
Right, so you often see persistent symptoms. Chronic pain is very common, could be aching, throbbing, swelling, especially towards the end of the day. A feeling of heaviness in the leg, like it's dragging. Fatigue in that leg specifically. Sometimes muscle cramps too. It's this constellation of symptoms that just lingers.
And the visible signs. You mentioned skin changes.
Yeah. Over time, you might notice hyperpigmentation. The skin, often around the ankle, gets darker, sort of brownish.
Okay.
And also something called lipodermatosclerosis. That's where the skin and the tissue underneath gets thick, hard, and kind of woody or leathery to the touch, usually in the lower leg, the gaiter area.
Right. And in the worst cases?
In more severe, long-standing cases, you can get venous ulcers developing. These are open sores, often around the ankle, and they can be really quite difficult to heal.
That sounds tough. Do the symptoms change day to day, like things that make them better or worse?
Yes, definitely. That's a key feature.
Yeah.
Symptoms typically get worse with prolonged standing or sitting, basically, when gravity is working against the blood flow.
Exactly.
And conversely, elevating the leg usually helps. It provides some relief from the swelling and the aching because you're helping the blood drain back out. That's a useful clue.
Any other signs?
You might also get things like just that persistent heavy feeling specifically in the calves, sometimes itchy skin pruritus, and maybe even new varicose veins popping up.
Okay. So we mentioned the ultrasound. Here's where it gets really interesting again. Investigating it. Is ultrasound the main thing, or are there other tests?
Ultrasound, the venous duplex scan, is definitely the workhorse. It's non-invasive, readily available, and gives a lot of information about both the structure of the veins and how the blood is flowing or not flowing through them.
Yeah.
Can it see blockages? Can it see reflux from damaged valves?
So it answers the key questions.
Usually, yes. In some maybe more complex cases, or if they're considering specific interventions like stents, they might need more detailed imaging.
Like what?
Things like venography, where they inject dye into the veins and take x-rays, gives a very detailed map. Or MRV, magnetic resonance venography, which uses MRI to look at the veins. But for most people, the duplex ultrasound is enough to confirm PTS and figure out the next steps.
Right. So what are the next steps? What does this all mean for treatment and management here in the UK?
The main goals are pretty clear. Make the symptoms better, stop the PTS getting worse if possible, and generally improve the person's quality of life.
And how do we do that?
A lot of it centers on conservative management, non-surgical stuff. Leg elevation, whenever possible, is simple but effective, just using gravity to help drainage.
Okay.
And then compression therapy. This is really key for established PTS, usually graduated compression stockings.
The tight stockings.
Yeah, they provide external pressure to support the veins and help push the blood back up, reducing swelling and discomfort. Regular exercise is also important. Things like walking help the calf muscle pump work better, improving circulation. Weight management if needed, because extra weight puts more pressure on the leg veins. And if ulcers develop, then really meticulous wound care is crucial.
What about more invasive options?
They're usually reserved for more severe cases or specific situations. Sometimes endovascular procedures can be done, things like angioplasty to widen narrowed veins or putting in stents to keep them open.
Inside the vein itself.
Exactly. Minimally invasive. Much rarer actual open surgery might be considered to repair or bypass damaged veins, but that's less common now.
And there's that important point about compression stockings. Something about prevention versus treatment.
Yes, really crucial clarification from recent guidelines. Currently, the advice is that elastic compression stockings are not routinely recommended just to prevent PTS from developing after a proximal DVT. The evidence didn't strongly support that for prevention.
Okay, so not for prevention across the board.
Right. However, they are still very much recommended as a cornerstone for treating the symptoms once PTS is actually developed. So important for management, less so for routine prevention after the initial DVT, if that makes sense. Along with leg elevation, of course.
Got it. That's a key distinction. So what's fascinating here is the long view. What's the outlook generally for someone with PTS? The prognosis?
It's quite variable, honestly. The long-term course really depends on how severe the PTS is to begin with and how well it responds to the management strategies we've talked about.
Right.
If symptoms are managed well early on, people can often maintain a pretty good quality of life. Consistent management is key.
But it doesn't usually just go away.
No, generally PTS is considered a chronic, long-lasting condition. The underlying vein damage is usually permanent to some degree. So while management helps symptoms, it's often something people live with long-term. And in some cases, sadly, it can lead to ongoing problems and even impact their ability to work or function normally.
Which brings us to the potential complications. This raises an important question. What else can go wrong as a result of PTS?
Well, the venous ulcers we mentioned are a major complication. They can be really persistent, painful, prone to infection, and need long-term, often specialist wound care. Chronic pain itself can be a significant complication, really impacting daily life and function.
Yeah, I can imagine.
And because the blood flow in the leg remains compromised, there's unfortunately an increased risk of getting another DVT in that leg.
Oh, right. Recurrence.
Exactly. And with any DVT comes the risk of pulmonary embolism, the clot traveling to the lungs, which can be very serious.
Okay. So let's try and pull the key threads together for everyone listening. The main takeaways.
Okay. So post-thrombotic syndrome, PTS, it's common after DVT, maybe affecting up to half of people. It's caused by long-term damage to the deep veins from the clot.
Right. Leading to persistent symptoms like pain, swelling, skin changes, sometimes ulcers.
Exactly. Diagnosis relies on history, exam, and especially that venous duplex ultrasound. Management focuses on relieving symptoms and improving quality of life.
Primarily with things like leg elevation and compression therapy for established PTS. Remember that guideline update, not routinely for prevention, but key for treatment.
Spot on. And understanding that it's often a chronic condition is important for managing expectations. Early recognition and consistent management are really the best bet.
Okay. Now, here's something to think about. We know PTS is pretty common after DVT. So what kind of maybe innovative strategies could we think about for spotting those at highest risk even earlier? Could we tailor prevention more effectively?
Good question.
And also, what role can we play in educating patients, making sure people know what subtle signs to look for after a DVT so they seek help sooner rather than later?
Those are really important points for future focus, definitely. Improving early detection and empowering patients could make a big difference.
Absolutely. Food for thought. And listen, if you're revising for the MSRA and found this helpful, definitely check out pastmsra.com for more resources.
And don't forget freemsra.com for even more free learning materials as well.
Great stuff. Thanks for joining us for this deep dive into post-thrombotic syndrome.